the Victory Studios in downtown Little Rock, this is Capitol View.
And welcome to Capitol View. I'm your host, Roby Brock. Thank you so much for joining us. Well, 6 months ago, Governor Sarah Sanders charged a working group to hold meetings to discuss solutions to Arkansas's lowest in the nation ranking of maternal health. From 2018 to 2020, Arkansas had 35 pregnancy-related deaths per 100,000 residents, and state officials believe that 92% of those deaths were estimated to be preventable. Let's talk policy and politics. I have an all-star panel with me today. Joining me is Renee Mallory, the Secretary of the Department of Health. I've got Janet Mann. She is DHS Deputy Director and Medicaid Director for the state of Arkansas, and State Surgeon General Dr. Kay Chandler, who is an OBGYN. So thank y'all all three for being here. Janet, I'm going to start with you first, all right? This big working committee that's been dealing with all of this, you guys collected a lot of data and want to collect more data. What is going to be collected that's going to be different than what you were collecting beforehand? What do you think has come out of this working group for that?
So I think the stakeholders, working with them over the 6 months and the conversations, we identified lots of areas for education and outreach throughout the state, working with the pilot counties. In addition to that, we identified improvements in Medicaid and clinical, and then really wanting to capture that data. And when we say data, claims data, when they go to the doctor, what is happening when they go to the doctor, so that we can have that actual data before, during, and after birth to make better decisions for care and coverage for pregnant women.
Yeah, Renee, I think one of the things that I have learned, I think over the course of all of this is that a lot of women don't go see a doctor early enough. You oversee a lot of the county health centers that are out there. What's going to change? How can you change that behavior?
So we have 92 health units around the state. Last year we did about 310,000 visits. So in 54 of those counties we actually provide maternal health. We're now up to 61, and we're constantly looking at those counties to see if we need to add services there. What we don't want to do, we're a safety net provider, meaning we only want to serve those areas where the services are lacking. So we're hoping, adding those services and getting those counties involved and looking at the services that are already there, we can make a difference in maternal health. When we looked at those prenatal numbers, we realized that women either seek prenatal care late or they don't seek it at all. So we're trying to educate about the importance of prenatal care and where you can obtain that prenatal care.
Okay, as Surgeon General, this is kind of your first foray into this big policy wonk discussion that we have here. What was your takeaway from the working group itself? Do you think it was as complete as it could be, and kind of what was your general takeaways?
Yeah, well, I thought it was great because there were dozens of organizations represented, over 100 stakeholders there that were participating. We just wanted to get as many ideas as we could, really, that from around the state. And I was very impressed with how that all came down. They met several times. I know I've met as many as I could on these groups, but just really to listen to ideas from throughout everybody that was participating, because they came from different perspectives. So that was great to hear that. And before we started this, people were having meetings and people were talking about it because they knew it was important. We knew we wanted to change it, but it would be, okay, this group and that group and another group. And so this was really a great way to just bring everybody together, everybody to the table, and then come up with a plan that we think is really going to make a huge difference and really help improve maternal health, babies, and lower that low birth weight and premature, all of those things to really help improve the health in our state.
Janet, I think one of the recommendations that came out that I want to get a little bit more description for our viewers and our listeners here is that you're going to pursue presumptive eligibility for Medicaid eligible pregnant women, which I think the interpretation you guys gave us in a press briefing that you did is that this will basically get doctors more willing to see some of these pregnant women, as well as making sure that there will be coverage there. on the front end. Describe presumptive eligibility.
So that is our hope. Presumptive eligibility is a shortened application process, and it's good for approximately 60 days by federal law. So we can presume they're eligible and give them some easy access to care early in the pregnancy and not be pending an application process and verification. So we're hoping, we heard from providers that was a barrier and a concern, because if they see the patient and they're not eligible, then Medicaid has an obligation to claw back that money. So we don't want to do that. We want them to be able to go to the doctor and have a doctor's visit, have some lab work, and do the early visit information that they need, and continue that process. Presumptive eligibility will be then followed by a full application, and we usually average 45 days or less to process those. So we're hoping that 45 days will cross over with the 60 days, and then there will be no gap in coverage or break in coverage.
Okay, you're a physician and you deliver babies, so you certainly know about this. This attitude of people not wanting to come in earlier and seek the care, some of it's cultural.
Yeah.
Some of it's financial. I mean, there's a lot of barriers there. What do you think can be done to change that mindset, that mentality?
Yeah, I really just am so excited about the educational outreach component of this, the campaign that we're going to do, to really just hope to get the word out. Listen, this is important. The earlier you start, really even before pregnancy. We really have to work on getting women as healthy as they can be before pregnancy, that preconceptual care. And I think that is something that's lacking even in people who have access, even in people who have insurance. They don't realize you need to go in before you want to get pregnant to make sure you're not anemic, to make sure you don't have thyroid problems, to check your blood pressure, make sure you're not pre-diabetic.
Diabetes, right.
I mean, those are the things that we're seeing. I think that we know it makes a big difference for the maternal health mortality and morbidity that we've seen, because it's chronic health issues they're coming into the pregnancy with already.
Yeah.
So if we do that beforehand, and I think it's just going to take really a lot of education, a lot of outreach, and to make sure that people know this, because I've heard too people say, well, in the health department sometimes we've heard, well, there's apathy. They think they've had fine in the last pregnancy, so they'll be fine this pregnancy. Maybe they don't realize that when you're younger, that increases your risk of teen pregnancy is preterm labor, but when you're older, 35 and above, that's where a lot of our maternal mortality and morbidity comes from. Yeah. So we just need to make sure we get all that good information out. I've learned even oral health makes a difference for how healthy a woman is and how her pregnancy is going to go.
It's interesting. Renee, talk to me about numbers and potential policy changes. This is going to be something where you'll champion. You guys don't have anything in those recommendations in terms of numbers. That wasn't your charge here for this working group, but that's the next step. So kind of talk to me about next steps.
So we are setting up an internal dashboard to, that Janet talked about. We did not have those numbers. Where we got the prenatal numbers were from our birth records, where women or the physician filled out where they obtained their first prenatal care. So now we're setting up an internal dashboard with some of these things that we will be able to track from the time that executive order was changed and going forward, so that we can see where we're actually making a difference, or if we're not, where we need to change some things.
How will that translate to the legislature? Just for anybody that wants to take this one up, how will that translate to persuading the legislature to give you more money for these things that you need? And how will you assess what laws might need to be changed in terms of, maybe it's not on the statutory books the way it needs to be?
So I think I'll take that, and anybody else speak up. But what we were tasked with as the strategic committee was putting all this together, getting the stakeholders together, figuring out where our resources are, coming up with these ideas to put in this report. Now that we've got those things, and we'll identify the resources, or where those resources are lacking, where we may need legislation or funding, we'll make those decisions now with this information that we have.
Gotcha. There was not a recommendation for extending the postpartum Medicaid coverage that has been a subject of quite a few conversations over the last several months, from I think 60 days to 12 months. Why was that not recommended? Why do you guys think that was not something that was recommended?
So we had 4 working groups, and all ideas were discussed, and the ideas and the recommendations that came forward were a compilation of all of those conversations. And I would just, go back to when we looked at it earlier last year. it would be duplicative. So we do not have a gap in coverage. Since we are an expansion state, we cover up to 138% of the federal poverty level for regular Medicaid, and we actually go above that for pregnant women to 209. And so we, one of the areas we did identify with streamlining and doing some things in our enrollment is really looking internally when a woman has a baby and she's eligible, where she could be in any category of Medicaid and still receive maternity benefits. But then if she's in a different category of eligibility after the baby is born and doesn't fall into Medicaid, working better with our partners in the federal marketplace for coverage is one of the charges that's coming out of this. So again, I think the coverage is there. We don't see a gap, and we've charged different people to look at the gaps in coverage, and I think we're going to work better to streamline some of the transitions.
And education and outreach will help that a lot. I got to wrap us up here, so because our time is running out, but I appreciate y'all being here. I hope that in some combination you'll all three, or maybe two or the three of you will come back at some point in time. We'll talk more about this subject. I'm not letting it go, and I know it's an important one for everybody. Dr. Kay Chandler, Janet Mann, Renee Mallory, thank you so much.
Thank you.
Thank you for
so
having
much,
us.
Robin.